Hello, I am Matteo Bassetti. I am a professor of infectious disease at the University of Genova and in the San Martino University Hospital. So my task today is discussing with you about COVID-19 and particularly about the COVID-19 management. These are my disclosures in the past 5 years, research grant, advisors, consultant, speaker, and chairman. So I like to start with you talking about a clinical case that has been managed in my hospital. 66-year-old male, jeweler with a medical history, just simple hypertension. On March 5th, developed fever, diarrhea, nausea, and cough. And on March 15, he presented to the emergency department for persistent symptoms. And the physical examination revealed bilateral crackles with a saturation of 94%. And the gas analysis show P over F 228. The blood tests reveal lymphopenia, increase in the CRP, and increase in the IL-6, and also alteration in the coagulation. The chest X-ray was that one with an interstitial pneumonia, and the nasopharyngeal swab was positive for SARS-CoV-2. We admitted to the infectious disease unit and it was treated with hydroxychloroquine, darunavir, low weight heparin, ceftaroline, 600 milligram BID, and after 24 hours, even with tocilizumab. On March 20, there was a worsening of clinical status and tachypnea and dyspnea. Respiratory rate was 32 with P over F 180. And we decided to start the CPAP with the PEEP of 10, but the respiratory rate increased to 35 and the P over F was 160. For this reason, we decided to admit the patient to the ICU and we decided to start remdesivir. And obviously you can see here the CT scan unfortunately show not only bilateral consolidation, but also pulmonary thromboembolism. And on March 22, the antibiotic was stopped and the clinical course was complicated with the catheter-related bloodstream infections due to coagulant staph that was treated with aptomycin. And on April 2nd was extubated and the nasopharyngeal swab was positive until April 8 and 13 where it was negative. Why I present this case? Because this case revealed the use of antibiotics in early and the course was complicated with the catheter-related bloodstream infections. So what do we know about the prevalence of secondary infections? So in general, according to the first report, there was a prevalence in around 110% of the cases of COVID-19. But more recent data show an higher prevalence of secondary infections with 50% of bacterial or secondary infections in non-survivors and only 1% in survivors. And this represents a key contribution to mortality. And this is very important to consider this point when we analyze data of COVID-19. And it is also very important, in my opinion, to look at the at the important heterogeneity of prevalence and incidence of infections across different studies because of the small sample size, because of some different diagnosis approaches, in reduced diagnosis approaches, in unusual clinical presentation, particularly for the anti-inflammatory agents, and for the early death from COVID-19 as a competing event, and even for different measures, prevalence versus incidence. So it's not easy now to really discuss about the correct prevalence and incidence across different studies. But in any case, we know from Chinese that there has been an intensive use of antibiotics at the admission. And you can see very well that we have the antibiotic use rate was almost 100% of the cases, between 93 to 98%, 95%. So almost all the patients with the COVID-19 with or without co-infections were treated with antibiotics. And in a couple of months ago, we published this position paper of the Italian Society of Infective Therapy and the Italian Society of Pneumology, in which we try to give to the colleagues some recommendation on how to treat these patients. And one of our first recommendations was that it might be prudent to consider empiric antibiotic treatment in critically ill patients with pneumonia due to COVID-19, in whom bacterial infection cannot be excluded. So we suggest to cover adequately for pneumonia. And this suggestion is based on the fact that bacterial co-infections is common in patients with viral pneumonia and can be associated with substantial risk of delaying appropriate treatment. So in our clinical case, we use ceftaroline, that is a very good drug for covering streptococcus pneumonia, and at the same time also to cover staph. So another important point is, what do we know about causative agents in COVID-19? We have 18 studies and 8 prevalence of co-infections with various microorganisms reported with different frequency in different studies, gram-negative, gram-positive fungi, and still unclear if causative agent of bacterial pneumonia is similar to patients with flu. I heard about important studies from China, which they have more or less 30 to 50% of co-infection with Streptococcus pneumonia. So it's very important to consider the potential role of this pathogen. So in our experience, we try to analyze which is the impact of bloodstream infections in critically ill patients with COVID-19. And this we include 78 patients and 45 bloodstream infection episodes. And we note that there was no or mild fever and low C-reactive protein in patients, particularly in patients with anti-inflammatory agents. And this is the cumulative risk of ICU acquired bloodstream infection. You can see the increase in relation to the days after the admission. And it's important also to look at which are the most frequent bugs. And the most frequent were coag staph in 24% of the cases, followed by E. coli, followed by Enterococcus fecalis. We have 6 episodes of Staphylococcus aureus and 1 episode of Streptococcus pneumoniae bacteremia. And probably the frequent use of 5th generation cephalosporin at the ICU admission increased probably the role of the pathogen that I mentioned before. So, which are the research needs for the future? It's important, in my opinion, to establish the exact incidence of bacterial co-infection and superinfections, and to assess diagnostic performance, and to better understand the contribution of infection versus immune response, and to assess the impact on the antibiotic use and resistance in all settings. So this is, in my opinion, very important. So based on that, again, on our recommendations, so because of the limited available data on both the microbiological epidemiology of bacterial superinfections, it is difficult to provide specific pathogen-oriented recommendation. And pending further study, we suggest to empirically treat COVID-19 patients according to the clinical course: community acquired pneumonia, hospital acquired pneumonia, ventilator pneumonia, choosing the best antimicrobial agents or agents on the basis of local guidelines or local antibiotic susceptibility patterns, with early de-escalation or discontinuation according to microbiological result whenever available. So the last message is regarding antimicrobial stewardship that I think is very important to discuss, because COVID-19, and obviously there is a potential role for coming back of antimicrobial resistant problem. First of all, because there is less opportunity for the isolation of infection MDR pathogen, potential spread of MDR resistant organism. Diversion of all PPE for SARS-CoV-2, potential spread. So we use PPE for SARS, but not for the MDR pathogen. Increased rate of empirical antimicrobial therapy, and we have seen data, 95% of the patients were treated with antibiotics, and then redeployment of antimicrobial stewardship team to deal with healthcare strains due to the pandemic. So there was less interest in effort for antimicrobial stewardship. And then rapid reorganization, recruitment of staff, loss of best practice, and overcrowding associated with the overall loading of healthcare system, major driver for the transmission of IMR, and depletion of structural resources, loss of side room capacity. So all of these points obviously increase the possibility to have some of the resistant pathogens. And then how COVID-19 is accelerating the threat of antimicrobial resistance. So patients with extreme symptoms and the physiological parameters that resemble severe sepsis and shock, not in a position to say definitely that the patients did not have concurrent bacterial infections. And critically ill patients are often intubated and hospitalized for a week. The usual cast of characters in any hospital acquire infections to make an appearance. So these are very important considerations, because I really believe that we have to more discuss in the future about the effort of antimicrobial stewardship for this kind of patients in order not to be back to the 80s. Thank you very much for your attention.